Hey everybody, welcome back to the ECG of the day. My name is Reed, and if you would like to, you can download the PDF of today's ECG document down in the description below and follow along and make your own notes. Save it for later, share it with your classmates, whatever you want to do. And don't forget to like this video and subscribe to the channel to help support our growth. So let's jump into it. And so the first thing I like to do is look at the forest and just understand what is going on with this rhythm. And so maybe I'll start here at lead 2. See, I've got a pretty regular rhythm. Just at first glance, it seems slow, but it's regular throughout the entirety of the strip. The QRS complex seems to be on the wider side, right? It looks to be a little wide, but regular. And so let's take a look at the rate. My rate here, this QRS seems to land kind of on a solid line. So maybe we'll go 300, 150, 100, 75, 60, 50. It's like 43, so maybe 40 beats per minute. So that's pretty slow. I would say we've got a pretty severe bradycardia and a wide complex bradycardia. So what's our differential for a wide complex bradycardia? This could be a ventricular escape rhythm, right? That could be caused by like a complete heart block or a sinus arrest. We could have a AV block of some sort, like we said. Maybe it's just a severe sinus bradycardia, right? Starting to think through a little bit. There's way more we can name, but you do note that there are some P waves, right? You look at these P waves are before my QRS complex. And so, okay, maybe this is a wide complex rhythm that's because of like a bundle branch block and it's driven by somewhere in the atria. So let's evaluate that P wave. What is the morphology of the P wave? Well, we see the P wave is upright in lead 1. It's upright in AVF. So these are, in fact, sinus P waves. Okay, and now we look at, well, what is the next thing in our puzzle? We've got the PR interval. It's our AV node. How's my AV node handling the P waves? And so I look at my PR interval, and so maybe I come here. I see this QRS starts on a solid line. This P wave starts before that solid line. So I would say my PR interval is within normal limits, right? PR interval is probably around maybe 180 milliseconds. And so that's normal. And I look at all the PR intervals, and they look the same. But I know that part of my job is to make sure that every P wave has a QRS. And we said that this bradycardia could be due to like a high-grade AV block. And so I look for P waves that don't have QRS complexes that are on this maybe STT wave segment, and then I have that. And that is a P wave looking sharp deflection, and look what it looks like. It looks just like the P wave that conducts to the QRS. And we have them all throughout this rhythm. And so, maybe my sinus node is beating twice for every one QRS complex. And if I look through, you see these P waves have been marching through this rhythm the entire time. Right? And so we've got P waves that are marching through the rhythm. We can make sure, are they sinus P waves or are they premature atrial contractions? Well, I would say the P wave morphologies look the same, but we know that we can also calculate our expected kind of, when is the P wave, when should it occur? So maybe if I draw a line through the peak of this P wave right here, I draw one through the peak of this P wave right here, and I draw one through the peak of this P wave right here, we can measure the space between and calculate it. So maybe we've got 5, 10, 15, maybe 19 millimeters between those two P waves. And then here we've got maybe 5, 10, 15. It looks to be about 19 millimeters as well. So what I'm getting at is that these P waves are occurring on time throughout this rhythm. But it seems that every other P wave is conducting to a QRS complex. And so if not every P wave is conducting to a QRS, we know that we at least have a second degree AV block, right? Because second degrees are defined by every other P wave, or not every P wave is conducting to a QRS. But we need to figure out what type. Is it a type 1? Is it a type 2? What is it? Well, we know that the difference between type 1 and type 2 is how the PR interval changes. But here's the problem, is right now we have 2-to-1 AV block. That means we have every other P wave is conducting to a QRS. So we actually, in order to qualify type 1 versus type 2 AV blocks, we need to have consecutive PR intervals to look at, right? We need to know if they stay the same or if they're changing. We don't have that. So we call this a second degree AV block or a high grade second degree block, right? And that tells us that we are unable to classify, but however, it's pretty significant. Still a second degree high grade AV block, right? With 2-to-1 conduction. Alrighty, so we have that dialed in. Let's take a look at that QRS. We said it's a wide complex QRS, right? We said the QRS is wide. If I look at it, it looks like, yeah, that QRS is a little bit longer than 120 milliseconds. So my QRS is wide, right? It's greater than 120 milliseconds or 3 small boxes. And so I know that since this is being likely conducted from these P waves, because I notice that there's a perfect correlation with this 2-to-1 atrial to ventricular conduction, well, maybe there's a bundle branch block. And so I look up at V1, and what do I see? I see we've got this RSR prime. See we've got this RSR prime. That tells me that we've likely got a right bundle branch block. And we can look and see in the lateral leads, we see these slurred S waves, And in V6, we also have a slurred S wave. And so those slurred S waves are even more data telling us that we've got late forces going away from the lateral leads towards the right bundle branch, because we've got a right bundle branch block. So we have that, okay. Now what else do we need to do? We need to take a look at our QT interval. QT interval looks okay, right? We know that the QT correlates to rate, and so you can see that that T wave is well within kind of our normal limits based on how bradycardic this person is, right? We know with bradycardia, the QT intervals usually increase, and with tachycardia, the QT intervals decrease because they correlate to the rate. And then I look for pathological Q waves and ST and T wave changes throughout, which tells us any active or prior myocardial infarction. I don't see any. And so if we put this all together, what do we have? We have a sinus rhythm with a high grade second degree AV block with 2-to-1 conduction and a right bundle branch block. And this person is on their way to getting a pacemaker, and that's what happened, right? Because a pacemaker is needed to make sure that those ventricles are getting stimulated after a P wave. And so we put in a dual chamber pacemaker where we have a pacing lead that goes into the ventricles, and we have a pacing wire that goes into the atria, and they can make sure that the atria and the ventricles, every time the atria beats, the ventricles beat a little bit after, and they synchronize so that we have good hemodynamic stability, right? And for a fun fact, for those of you who stayed for the whole video, go to the last video. This is the same patient from the last video, right? This was a later ECG, right? Years have gone by, and this person's conduction system just got more and more diseased. So it's pretty fun to look at how these things change and why follow-up is important, right? And why identifying the anatomy of the lesion is even just as more important, right? Know what the risk is if things progress in the future. And here we were. This patient got a pacemaker and did great, and is likely, a lot more symptom-free every day. So I hope this helps, and if you have any questions, throw them down in the comments, and if not, thank you so much for watching. We'll see you on the next ECG video. Have a great rest of your day.